We're now going to begin program 3 with chronic lymphocytic leukemia, know when to start and when to stop, presented by Dr. Rodney Cosfeld. Dr. Cosfeld is a Louisville native, graduated from the University of Louisville School of Medicine, completed his residency and fellowship, ultimately with the Division of Hematology in that department. Is a member of various professional societies, including the American Society of Clinical Oncology, American Society of Hematology. He's presented at several highly notable presentations for AFCR and national meetings. Dr. Cosfeld's extensive research involvement has afforded him the opportunity to publish in numerous groundbreaking research and journal articles that exemplify his expertise in the field of hematology. Dr. Cosfeld.
Well, the title of my talk is Know When to Start and Know When to Stop. Somehow it makes me think of poker advice. No disclosures to report. Now, what I'd like to give some historical perspective, as being a historical person myself, talk about the current agents available for the management of CLL and how they are being looked at, explored for the best way for combining or sequencing therapy. And we've addressed what the title means. The title, When to Start and When to Stop, I think applies to the use of the newer agents. Do we use continuous therapy or do we take advantage of some of the time-limited possibilities that we'll address in a moment? So chronic lymphocytic leukemia historically has been regarded as a controllable but not a curable disease. The risk factors when I started out were based upon tumor burden and morphology. The Rye and the Binet staging criteria were really based on the number of lymph node sites and whether or not there's bone marrow failure. Stage C, Binet, would be bone marrow failure, and that would be associated with a 1 to 3 year survival. So we would generally treat before somebody reached a stage 3. Now, currently, genetic factors are the most important features of determining about how to manage the CLL at this point. We'll talk about later. Now, since this is not a curable disease, we've always started treatment when the disease demands it. We would often see people with a diagnosis of CLL, but until they demonstrate progression of the disease, like from stage A to B, but before it goes from B to C, we would start treatment. And initially, we only had alkylating agents and prednisone available, and leukeran and prednisone, chlorambucil and prednisone were the only initial therapy. And clinical remissions were achievable, but there was invariable relapse. You could get a second and later remission, but each remission was of decreasing depth in duration. And unfortunately, we could pretty much figure out how long a person was going to live after the first 2 or 3 courses of therapy. This is a rough timeline of the recent developments in treatment of CLL. The alkylating agents derived from the mustard gases used in World War I, and they were used as primary therapy until about the 80s. Chlorambucil is still used as a comparator, particularly in European studies. I don't think anybody in the US uses chlorambucil for primary therapy of CLL any longer. We were delighted to get fludarabine in the 1980s. Fludarabine is an alkylating agent that interferes with the growth of the tumor cells. Rituxan and other immunotherapy monoclonal antibodies were developed in the 1990s, and Rituxan first became available in 1998 and became a mainstay in treatment of higher grade non-Hodgkin's lymphomas long before it was available in CLL. And then the high water mark of chemoimmunotherapy came in 2008 with the proof of FCR, fludarabine, Cytoxan, and Rituxan as a standard agent in the management of fit patients with CLL. Now, this is a very busy slide, but I only want to take a couple things out of it. One, this is the overall survival of several 300 patients who were treated at MD Anderson with FCR. Now, they were collected between 2013 and 2018. Actually, I had that wrong. This was published in 2008, and this was before we had the genetic tests, by and large, and these were a mixture of patients with higher risk genetic lesions. They did eliminate the 17P minus, but what we saw here was the people who got a good complete remission. This is 72 months. That's 72 months survival, and a large number of people were still living without living at 72 months. Here, there's been a continuous relapse of disease, but relapse didn't correlate with a quick death. Now, this slide represents patients who are stratified by whether they had a complete remission by FLC, that is a flow cytometry. If they had less than 1% remaining bone marrow leukemic cells, they had a much longer survival. And then this is the progression-free survival in people who actually were PCR negative. This was this is MD Anderson, and they did a gene probe based on each individual patient's variable region. And so they were able to identify those who had 10 to the minus fourth versus 10 to the minus second and less than 10 to the minus second decline. And this illustrates really quite well that even with the available PCR testing at that time, that those who had the deeper response had the longer remission. Now, this is from the NCCN guidelines, looking at the genetic abnormalities that influence prognosis. It turns out that the interphase cytogenetic, or FISH, was published in 2010, and the most important abnormality was the deletion 17P. But it turns out that on subsequent studies on DNA sequencing, any abnormality in the P53 was a high risk factor. That is, people receiving chemoimmunotherapy would have short survival times in the presence of either a deletion of 17P or a TP53 mutation. And then the other genetic sequence abnormality was whether the IGHV was mutated or not. Mutation being defined as less than 98% germline identity. So this becomes important in ongoing studies. Now, this begins a series of studies reported at the recent ASH meeting. This was called the FLAIR trial, where they compared under 75-year patients who are 17P negative, but not necessarily TP53 negative, using ibrutinib or rituximab versus FCR. And the FCR was given in the same way as the FCR in the 2008 paper. They were stratified for Binet stage and the IGHV. It turns out, though, the progression-free survival was not better whether or not there was mutated, or if there was not mutated IGHV. Crossover was allowed, so the 4-year overall survival was better in the FCR arm than was in the 2008 study. And importantly, there were 8 sudden deaths In the ibrutinib arm, 7 had previous cardiac disease. Also, there were 8 secondary myelodysplasias and AML in the FCR group and 1 in the ibrutinib group that is important for future considerations. And this represents the progression-free survival, and the average here, the median was less than 48 months, but you can see a clear difference in the FCR versus the ibrutinib Rituxan. And incidentally, other studies have shown that the Rituxan doesn't add anything to the durability of the progression-free survival with ibrutinib. And now this is looking at single agent ibrutinib or ibrutinib Rituxan compared with bendamustine Rituxan chemoimmunotherapy, a phase 3 study. It was stratified for Rye stage, which is similar to Benet, ZAP70, 17P minus, 11Q minus. Again, it was done between 2013 and 2016, 547 patients before we had the deep gene studies. And it was a crossover design again, so that if you failed one, you could go to the other. And it turns out that the progression-free survival was not different at all between ibrutinib with or without Rituxan. What was clearly superior to the bendamustine Rituxan, but the overall survival was not different, in part due to crossover design. Now this looks at another ibrutinib variant. The zanubrutinib is a cleaner next generation bruton tyrosine kinase inhibitor in a phase 3 open label comparing zanubrutinib and bendamustine Rituxan. And again, this is a fairly short study, certainly too short for evaluation in the chronic lymphocytic leukemia. There were 450 some odd patients, and about the median was at about 21 months, but there was a clear separation in favor of the BCR inhibitor. Now, the current NCCN guidelines would give us 4 options in patients who are 17P 17P minus negative or P53 negative, either one of the currently available BCR inhibitors or a BCL2 inhibitor we talk about later. The only circumstance where the chemoimmunotherapy is still a recommended item in first-line therapy would be for young fit patients using FCR if there's IGVH mutated CLL. But basically we choose between a BCR inhibitor versus a BCL2 inhibitor. And this is the recommendations for first-line therapy in patients who do express a P53 mutation or defect. And here, the only difference is it's the same 4 options, but the option of chemoimmunotherapy has been basically eliminated. So the decision on the initial therapy for the CLL, we strategize to maximize response and minimize the duration of therapy. And whenever we start, we have to consider long-term what to do next. The initial BCR inhibitor trials in advanced resistant disease were continued until there was relapse or serious adverse effects. These are the ones that first demonstrated utility. And we found that venetoclax could induce deep enough remissions even alone to introduce a possibility of time-limited therapy. But we're left with a question about how best to combine or sequence the targeted agents to maximize long-term disease control and limit side effects. So This was a study looking at adding ibrutinib to FCR. FCR used in the same way as the other study. It was in first-line therapy in young, fit patients where people would get up to 6 cycles. They would start an ibrutinib and then get FCR up to 6 cycles, continue the ibrutinib for 2 years, and then stop if they had a bone marrow unmeasurable minimal residual disease. And this did include the P53 patients and also unmutated IGHV. Now, this is early. The mean observation is only about 40 months, but we can see that there has been the overall survival is very good, and the progression-free survival is also good. And then this is a report of using venetoclax plus ibrutinib. We have some local talent included here. And this report looked at the depth of the minimal residual disease, looking at outcome compared with Rituxan and obinutuzumab in older people that are P53 mutation negative, stratified by the IGHV and deletion 17q. They received 3 cycles of ibrutinib, then 12 cycles of ibrutinib and venetoclax versus 6 cycles of chlorambucil and obinutuzumab, which we'll not further discuss. The primary endpoint was progression-free survival and the rate of undetectable MRD defined by less than 10 to the minus 4th by PCR. And the MRD was assessed at 3 months after completion of treatment and again at 12 months after completion of treatment. Now, this is a busy slide, but looking at this panel, this represents 50% of people had at least 10 to the minus 4th MRD. And then this looks at the effect at, this is the same here, this is the effect at 12 months. They still have about 50% of MRD less than 10 to the minus 4th. And this is continued. This is something we'll be watching for future decision making. And this is Captivate. I wanted to show this for one thing. This is another fixed duration of ibrutinib and venetoclax that is MRD driven. So another strategy is to determine whether to continue treatment based on MRD. They got 3 months of ibrutinib and 12 months of ibrutinib plus venetoclax, the same kind of program. And then at 16 months, if they still had, or if they had a 10 to the minus 4th undetectable MRD, then they were randomized to ibrutinib versus placebo. And those without were continued on either ibrutinib or combination. And then this is an early study. The time for randomization, the mean was only about less than 2 years. But we can see that there was not an obvious difference early on between the ibrutinib and placebo. But this is another one we'll be watching. And so finally, to choose between time-limited and continuous therapy, there are no direct comparisons available. We make our decision based on patient factors, presentation, and disease factors. And patients who have comorbidities, we would prefer to use something like the second or third line or generation BCR inhibitor. Sometimes medications play a role. The proton pump inhibitors will interfere with the plasma levels of the venetoclax, of the calibrutinib. And if patient has inconvenient access, we basically cannot use the venetoclax because we have to watch so closely on initiating therapy. And then patient preference, most would prefer a limited duration therapy rather than long-term because of cost and side effects. And then again, the high tumor mass, if there's a high tumor mass, then venetoclax is harder to use. And we'd probably like to reduce that before initiating that. And then disease factors really come into play in terms of choosing the targeted agents versus chemoimmunotherapy. And so we're future prospect. There are cleaner agents that are becoming available. There's one called pirtobrutinib that probably is more potent and less toxic. We're waiting for clinical availability of the MRD assays, and we're waiting for the outcome of the current ongoing therapies.
Thank you very much, Dr. Kosfeld. Are there any questions, Mark?
Can I ask a question?
You may ask a question, Dr. Edwards.
I want to ask Rodney, Don, and Judd this question. With all these new things, even though we say we use FCR for the young, healthy, fit patient, do we ever really use it? I never see it used anymore. It's pretty rough.
It's still the academic center treatment of choice. But I think out in the public, that most people would go to anything but the FCR. If you can tolerate the FCR, you might or might not get long-term control.
And you might get leukemia.
You might get leukemia too. So
I'm not successful. I've used it once probably in the past 5 years, and it was unsuccessful.
I have not used it in the last 5 years.
Yeah, that's the feeling I get.
Yeah.
We
I haven't used it at least one.
Thanks again, Dr. Kosfeld. That was wonderful. Our next program is allogeneic cell therapy, off the shelf, off the chain. And our presenters are Dr. Becky Champion and Dr. Kylie Pagan. Kaylee. Dr. Champion is the clinical pharmacy specialist for our heme malignancy and cellular therapy program. She has worked for Norton Healthcare for almost 17 years, the last 14 of which were with the with the Norton Cancer Institute. She was instrumental in the creation of our blood cancer program. She is a member of the American Society of Hematology and a board-certified oncology pharmacist. She is widely known as an expert in the drugs used to treat the diseases we're discussing today. She is an excellent communicator and serves as an always accurate resource for both patients, families, and staff. Dr. Pagan is a postgraduate year 2 oncology resident at NCI this year. She completed her PGY1 at St. Joe's Hospital in Lexington. She was born and raised in Florida. She attended the University of Florida, where she completed her undergraduate requirements and doctorate of pharmacy. Her areas of interest include hematologic malignancies, oral oncolytic therapy, and patient education. Welcome, Drs. Champion and Pagan.
Thank you so much for that introduction, sir. So our talk today will be about CAR T therapy or cellular therapy, but we're actually going to focus on allogeneic cell therapy, off the shelf and off the chain. It's a very clever title. These are our disclosures. Our objectives today, we're going to summarize current therapy options with autologous cellular therapy. We will discuss the rationale for the use of allogeneic cellular therapy. We will analyze the risks and benefits with allogeneic cellular therapy. We will summarize the various cell therapy modalities that are available. And then finally review some of the allogeneic cell therapy clinical trials that we have available here at Norton Cancer Institute. So I'll start with the autologous cellular therapies that are currently available. You can see that our first cellular therapy was FDA approved in 2017. That was tisagenlecleucel or Kymriah. It was FDA approved for the treatment of relapsed refractory pediatric and young adults with acute lymphoblastic leukemia. Since then, it's really exploded in terms of not only the products that are available, but also the indications that we treat. We have options available for patients with diffuse large B-cell lymphoma, with relapsed refractory follicular lymphoma, mantle cell lymphoma, and we also have 2 products that target the BCMA for patients with relapsed refractory multiple myeloma. So just to look at the autologous CAR T process, the process starts with the patient. The patients are leukapheresed, which means that we take off their T cells and we send them to a lab. After they are pheresed and those cells are at the lab, then they are injected with this CAR-coding viral DNA. It's incorporated into the patient's T cells and is really designed to attack what we tell it to attack. So for most of the products that are available, for example, CD19. Those CAR cells are then expanded, they are evaluated at the lab, and then they're sent back to the patient where they are infused after the patient's received some lymphodepleting chemotherapy. From the time a patient is leukapheresed to the time they actually get their infusion is somewhere in the realm of 4 weeks for these patients. Oh, we have an animation, so sorry. So there are several advantages and disadvantages to autologous CAR T. Remember that these are the patient's own cells. So from an immunologic perspective, these are associated with the absence of an allergenic reaction. Because they don't have an allergenic reaction, these engineered T cells can persist for a long time. But unfortunately, there are disadvantages to the autologous CAR T products. And we'll start with the production time. Remember, from the time that you identify a patient as potential for CAR T to the time they actually get their infusion is probably around 4 weeks or so. And because these patients have relapsed or refractory disease, oftentimes we have to give them some type of bridging therapy to try to keep their disease under control until we get those cells back. And I say when we get those cells back, unfortunately, I need to say if we get those cells back, because that's not a guarantee. These patients, they're heavily pre-treated, and unfortunately, manufacturing failure happens in almost 10% of some of the clinical trials. There's a variety of different reasons that this could happen. This could be in part due to T cell dysfunction. This is a hallmark of many cancers and is associated with multiple mechanisms of immunosuppression. We actually have a patient of Dr. Malley's who just went through this whole process. So unfortunately, we're trying to still figure out how we can give this patient some cellular therapy. And then lastly, this is expensive. This is hundreds of thousands of dollars for every patient to get cellular therapy. So we cannot forget about the financial toxicities associated. I think the takeaway message here is that this is definitely beneficial for a lot of our patients with heme malignancies, but this is not for everyone. And so that is where allogeneic cellular therapy comes into play. So when we talk about allogeneic cell therapy, we start with healthy donors. This is starting with healthy donors. These patients get apheresed, and then we have a wide array of different types of cells that we can use. We can engineer these cells with this CAR gene insertion or gene editing. We also can just use their natural cells to fight malignancies. But as you can see, that gives us an off-the-shelf product that we are able to store. We can also expand these cells and treat multiple patients. So as we think about some of the barriers that we talked about with autologous products, as we look at allogeneic products, these are potentially could be cost effective. Remember, we can expand these and treat many, many patients with just a single donor. We can also have these products readily available. This also gives us a higher quality product. Remember, we're starting with healthy patients that have not received chemotherapy or radiation. And we can also use a variety of cells available from each of these patients. So now we'll talk about finding the right fit.
Yes, thank you so much. So when we're talking about finding the right fit for these patients, we're talking about the different types of modalities we have within allogeneic cell therapy. This isn't necessarily a one-size-fits-all model. And I think the best way we can get started with that is understanding the difference between engineered and non-engineered products. So as Becky mentioned, we have a CAR domain that's linked to an intracellular signaling domain. In our first generation allogeneic therapies, we see that that intracellular signaling domain is the alpha beta T cell receptor. We'll talk about this a little bit later, but basically this increases our risk for toxicities, but it has an extremely cytotoxic effect. So we're seeing that patients are deriving benefit from this, but we're also increasing their risk of downstream effects. Through engineering, though, we can avoid a lot of this by avoiding the alpha beta T cell receptor and utilizing other cellular signaling domains that are cytotoxic without having toxicity. The things that we'll talk about today are our natural killer cells, our gamma delta T cells, and then our invariant NKT cells. What all of these do in turn is reduce that risk of toxicity while maintaining therapeutic action. We'll go ahead and get started with our non-engineered therapies, and that is our alpha beta T cells. What we know most about this comes from a lot of our stem cell transplant history and a lot of the data that we've derived there. We know that alpha beta T cells are a key mediator in transplant rejection and graft versus host disease. And a lot of this is because they're important for recognizing foreign and non-self antigens that are presented on the major histocompatibility complex, or MHC. What we want to think about is making sure that that HLA typing in transplants are similar from the donor and the patient who's receiving therapy. It's very similar in allogeneic therapies. We want to make sure that we have some compatibility. It's not necessarily required, but we can see an increased risk of toxicity if we don't have that. So you're probably asking yourself, why are we using this then if we know it's extremely toxic? Well, alpha beta T cells are extremely prevalent, and almost 90% of all of the circulating T cells that have a T cell receptor have this alpha beta chain linked to it, making it a really great candidate, especially at the beginning of our research when we were looking for how we can best make these off-the-shelf products. As we've gained more information, though, we've started to find new or engineered ways to make this work. One of those ways that we can do this is by using a gamma delta T cell as our signaling receptor. What the gamma delta T cell does is it's helpful for tissue homeostasis as well as cancer immunosurveillance. The way this does it is by recognizing cancer through multiple different receptors, but avoiding that MHC complex. In turn, we think that this lowers our risk of toxicities like graft versus host disease, but still maintains some cytotoxic effects for the patient. Another mechanism we can use is the use of our invariant natural killer or iNKT cells. They have a very broad functional scope. What they use is the natural killer and the T cell properties to impart both what it does is it shares both of these properties with the natural killer and the T cells. And what it in turn does is it gives us a cytotoxic effect, but does not use that MHC complex. It utilizes other complexes once again. And we actually see that these can be protective against graft versus host disease and other types of toxicity effects that we have. Now, looking just at natural killer cells, those iNKT cells that we talked about earlier are actually a subset of these. So we first found these natural killer cells, and then we were able to locate that subset of them. But natural killer cells themselves are still very helpful. They do have a low risk of graft versus host disease and other toxicities as well because of their innate anti-cancer properties. We are able to produce these from numerous sources. So beyond just using peripheral blood from a donor, we can also use fetal sources as well, and multiple different areas of research are being utilized on how best we can obtain these cells to make them viable and more available for our patients. What we've also noticed in our preclinical studies is that these actually not only demonstrate activity in our heme malignancies, but are also going to be viable options for some of our solid tumors. Here at NCI, we have some studies looking at that. However, that's not the focus of our presentation today, so I won't get into the nitty-gritty there. Now that we know a little bit more about the different products, what is the cost of these? And I'm not talking about the financial impact, that we already went over that, but I want to talk about those potential risks. With allogeneic CAR T, we have a new subset or a new set of toxicities that we worry about. With autologous cellular therapies, we worry a lot about cytokine release syndrome and neurotoxicities. However, when it comes to allogeneic cellular therapies, this isn't always the case. One of the big things that we worry about is graft versus host disease. As I mentioned earlier, because of those alpha beta T cell receptors and our body's ability to recognize that we have a foreign product, we're actually seeing that the immune system is rejecting the cellular therapy itself. This causes tissue cell death in common areas like the liver, skin, and GI tract. Once again, this is very similar to that donor-recipient HLA disparity that we see in stem cell transplants. And there's actually some work and some data looking into how we can best match these off-the-shelf products to specific patients. What we see with graft versus host disease is an increased risk in morbidity and mortality that can be extremely detrimental to our patients. Having patients that have undergone transplant here at NCI, we see that many have issues with graft versus host disease years after their transplant. So now they're not only dealing with their cancer diagnosis, but the other toxicities that are associated with it. The other concept that I think is very important that we highlight is immunogenicity. So as we talked about autologous cellular therapies, we have these long-lasting remissions. And a lot of this has to do with the persistence of the CAR immune cells. However, in allogeneic therapies, we see not only the CAR is foreign, but also that linker that we're using is a foreign product to our body. So what's happening is the host immune system is recognizing this and causing rapid elimination. What we can do to minimize this risk or really mitigate it is making sure we're using effective lymphodepleting chemotherapy for patients prior to administration of these products, as well as making sure we use genetic modifications of CAR products as well. So those engineered products that we're using can help in the forefront to prevent these long-term effects. However, one of the benefits to allogeneic cell therapies is the fact that we can give repeat administrations. With autologous cellular therapies, we're limited a lot of times to that one and done opportunity. With allogeneic therapies, we're able to utilize multiple opportunities to give patients cellular therapy in terms to give them complete response. Now, I know we've talked a lot about the toxicities, but I don't want to take away from the fact that these are beneficial medications. And as we continue to see more in the research, we'll learn more about what those long-term effects will be. Becky's going to talk a little bit later about some of the research that we're doing at NCI, but I do want to take a moment to really pause and recognize that these aren't benign medications that we've been discussing. And actually, the FDA has recently halted one of the allergenic CAR T therapies because of safety concerns. They had one patient in this study who ended up having chromosomal abnormalities after administration of cellular therapy. And I think it really just goes to show we've got a lot more research to do and a lot more understanding. So now I'll hand it over to Becky to keep up with the times on what's going on here.
Thank you. So I just wanted to talk about the cellular therapy studies that we have available for our patients here at NCI. The first is LYM 2085. This is a phase 1 study of an allergene product. This is Allo 501, which is an anti-CD19 allogeneic CAR T product, and Allo 647, which is an anti-CD52. We're looking at this in the relapsed refractory large cell lymphoma or follicular lymphoma space. I think it's interesting that they're coming up with their own anti-CD52 monoclonal antibody, think Campath or alemtuzumab. This is a potent immunosuppressive agent. It's thought that if we can suppress the immune response, then we can allow better CAR expansion. The next study that we have available is LYM 2086. This is a phase 1/2 study looking at a slightly different product. This is another allogene, Allo 501A. This is an anti-CD19 allogeneic CAR T, but this actually has a pocket with a CD20 recognition domain. Think of it as a suicide switch. Just as Kaylee mentioned, these drugs are not benign. So in thinking that we needed to quickly eliminate these drugs out of circulation, they put a suicide switch in where if we needed to get rid of them, then we could give the patient Rituxan and effectively take these cells out of circulation. The next study is LYM 2088. This is an Adicet bio study. This is anti-CD20 CAR engineered gamma delta T cells. This is being studied in the DLBCL, the MCL, transformed follicular lymphoma, as well as follicular lymphoma, marginal zone lymphoma, and primary mediastinal B-cell lymphomas. And then the last study that I wanted to highlight is EP 2156. This is a phase 1 study that is looking at invariant natural killer cells. The important thing here is that these are not genetically engineered. We're looking at this in the relapsed refractory solid tumor space. So we are looking at this in patients, for example, with cervical cancer, with breast, prostate, even pancreatic cancer. And at different dosing, we actually had 6 patients that were enrolled in our COVID cellular therapy study for this. With that, I will take any questions or comments.
Thank you both very much. That was wonderful. Any questions?
Can I ask a question?
You may, Dr. Henley.
When I first started reading about off the shelf, what I read was they were going to try to cut out the HLA antigen from the T cell so that if they infuse that T cell into me, I won't reject it right away. Is that what, have they cut the HLA antigens out of these cells?
In some of them they have, but some of them it just has to do with the fact that those invariant NKT cells are not very immunogenic, if you will, and they in theory last longer. But we still have a lot to learn in terms of how best to do the lymphodepleting therapy, what dose of cells to give. And as Dr. Pagan mentioned, one of our studies, maybe one or more, actually allows us to get more than one dose. So, for example, if you cleared a tumor but then had persistent disease or recurrent disease at 60 days or 90 days, you could get another dose of cells, for example. I mean, all of that is, and the fact that we're also looking at even the engineered allogeneic products are looking at different antigens. One of the disadvantages of all the autologous CAR Ts we have is they're all geared towards CD19. And so we've had actually several patients referred in who've failed autologous CD19 directed cellular therapy for this clinical trial looking at allogeneic CD20 directed therapy.
Okay. Interesting.
So you can design these cells around different antigens to attack and look at them in terms of what T cell subpopulation you want.
Do you think there'll be a role for PharmDs in the future with all these cells floating around?
Yes, Dr. Hadley, I'll answer that question. I'll field that one, sir. Yes.
Well, I do think it's interesting that these products are being developed by companies that are working through the FDA process. In other words, this is, as you would
They're
expect,
considered drugs.
they're considered drugs. So, it seems a bit weird to have, Dr. Champion, Dr. Bacon refer to this as this drug versus that drug. They're really thought of as drugs. They're living drugs. One of the consequences of having hematologic malignancies is the need for frequent, sometimes scheduled, sometimes not scheduled hospitalizations. And much as in every other scenario that we treat at the NCI and in oncology, it is vital that we have the assistance of our behavioral oncology colleagues. And so to present this session, treating depression in inpatients with blood cancers, when you're in, you're down, is Elizabeth Archer-Nanda. Dr. Archer-Nanda has been a nurse in oncology for 21 years, 17 of which is a board-certified psychiatric clinical nurse specialist. She was the founding provider and it remains the program leader of the NCI's behavioral oncology program. This was established in 2004 and has continued to grow and meet the needs of our patients and their families. Her professional memberships include the Oncology Nursing Society, the American Psychiatric Nurses Association, and the American Psychosocial Oncology Society, a society that she is currently the president-elect for. And she is also a member of the Kentucky Board of Nursing Advanced Practice Council and a medical advisory member for Gilda's Club here in Louisville. Dr. Archer-Nanda is interested in the development of sustainable models of psychiatric care with expertise and tenure in psycho-oncology. She is an advocate for a positive work culture, an advocate for her colleagues, for inclusivity, and a just work environment. Through her work with the Norton Provider Leadership Academy, she's been working to establish protocols for clinically appropriate and the safe use of benzodiazepines. As a clinical nurse specialist, she is continually seeking opportunities for improving the care of our patients, and I welcome you, Dr. Archer-Nanda.
Thank you very much. I will go on and share my screen here. And start my slideshow. Can you all see it okay?
We can, yes, thank you.
Perfect. And you can hear me okay, I hope.
Yes.
I snuck in that I will also talk a little bit about other mental health conditions, but we'll keep it mostly to depression, as Dr. Stevens mentioned. So I want to talk a little bit about the language that you use and that we use is really important. So as you can tell here on my disclosure slides, I took it a little bit of a different direction. I really can't talk about my childhood. Before I left home, they made me sign a confidentiality agreement. And also, we'd appreciate if the patient would sign this agreement to not disclose any of the gossip overheard by the staff during their stay. I also don't have any financial disclosures to report, but I think as I listen to the talks here today, what we do is common for us, but it is very uncommon for the patients that we see. So how we say things is relevant to people, especially as they are coming from different perspectives, upbringing, experiences, educational backgrounds, and so on. So as healthcare providers and also leaders, it's important for us to come to a place of meeting patients where they are to ensure that they adequately understand things, as well as they can understand the treatment pathway that we would like them to be on. I had actually not heard of a suicide switch until Dr. Champion's talk here just recently. And of course, that had totally different implications in my own mind. So just looking at how we say things and what we say and attaching meaning to it in different ways as different types of providers. So I will move on. The objectives of this talk are to understand the risks of mental health comorbidities in patients with hematologic malignancies. We're going to talk a little bit about unique patient characteristics contributing to mental health vulnerability, and also explore opportunities to reduce burdens associated with depression and anxiety. I like Dr. Altus's talk earlier today, talking about radiation as a solution for helping reduce anxiety and treatment as a treatment intervention in low-grade lymphomas. And we heard other providers today too talk about financial toxicities and other things that come up for our patients, making the mental health journey very, very complicated oftentimes. So what we know is that unresolved depression affects physical symptom severity, risks treatment interference, specifically looking at treatment non-adherence. It interferes with coping capacity and it can reduce an individual's quality of life. So research actually does correlate depression with increased mortality in medically ill populations, as well as mortality risk associated with suicide in the context of depression. And then prolonged and repeat hospitalizations actually place patients at greater risk for a burden of psychological and physical symptom distress. So today we're going to talk broadly about depressive disorders. So in the DSM-5, it's important to note that this can include disruptive mood, mood dysregulation, major depressive disorder, persistent depressive disorder, which previously was known as dysthymia, premenstrual dysmorphic disorder, substance-induced or medication-induced depression disorders, and then also looking at other depressive disorders. So the common feature across these disorders is sadness or emptiness or irritable mood, and they can have somatic overlay as well as cognitive overlay. Depression is characterized by a period of 2 weeks or longer, whereas dysthymia would be a period closer to 2 years in adults. And then it's beyond the context of this talk, but it's also important to highlight that delirium or that acute confusional state is very common in this population and does carry a really high risk for mortality. So depression rates in cancer patients, it's widely reported to be anywhere from 8% to 24%. Some studies even have said that it could be as high as 60%. So they're generally conducted across cancer types without specific examination of hematologic malignancies. But Lou and colleagues looked at hematologic inpatients specifically and identified that in this cohort of 58 patients, 29.3% of those patients experience clinically significant depression as determined by a PHQ-9 score greater than 10. So we've also noticed in that study, as mentioned, that those patients experience higher rates of delirium as well as more significant drowsiness. So patient characteristics and risk factors that are important to note, looking at any previous history of depression or anxiety, individuals who have advanced cancer, people with poorly controlled pain, social isolation, people who are under undue stress or experiencing a loss. And if we think about this population, everyone's under some stress and they are experiencing loss of their health. Sometimes it's loss of their income. Sometimes it's loss of family routines, and it places challenge on their social systems as well. So it's easy to say that our patients are at great risk. If they've had any history of suicidal ideation, difficulty with worthlessness, patients will sometimes complain about chemo brain or cognitive slowing, which places them at greater risk for depression. Individuals who experience difficulty with fatigue, insomnia, loss of interest or enjoyment, and even looking at difficulty with fear of reoccurrence or worry around their cancer. Depression is reported similarly across Caucasians, African Americans, and Hispanic and Latino groups. But the Lou study actually showed that it was doubled in African American patients, which is important for us to note. I think I mentioned previously that pain and physical suffering can negatively contribute to a patient's risk for depression. Interestingly, depression and anxiety, as well as generalized anxiety, was found to be higher in women. And there was some higher prevalence in depression in newly diagnosed cancer patients. Fatigue, pain, and impaired quality of life are all highly correlate with the experience of depression, with fatigue being the most significant. So Dr. Stevens mentioned earlier that sometimes patients are admitted for predictable admissions and sometimes it's unpredictable. So unplanned readmissions are very, very stressful on patients. They experience difficulty with fatigue, reduced well-being, drowsiness, pain, poor appetite. And even in these hospitalizations, they're not always under the understanding of what it is that they've maybe done wrong. And there's a lot of experience of self-blame and disappointment that perhaps they couldn't make it through their treatment regimen without an unexpected admission, or they've done something to let the treatment team down or something like that. So much of what our patients are thinking, feeling, are unseen for us, and it creates a challenge for patients, their caregivers, and their healthcare providers. So these are some of the unseen and unspoken burdens that our cancer patients experience. So in many circumstances, as I was mentioning, patients want to be seen as good and doing what they've been told. They want to be a good patient. They want to be seen as being adherent, and they want to get through their cancer treatment as quickly as they can with as few hiccups as possible. So coming in for these unexperienced admissions, they may perceive themselves to being a bother to their healthcare team. They may be insecure or experience shame around any additional mental health burdens that they're experiencing and feel as though they've failed in some way. So they feel like they've been let down by their bodies. They're grieving changes in their health. They're grieving changes to their interpersonal and social functioning. And these are just some of the words that are used in the literature looking at how patients might feel from a psychological, emotional perspective. You can see on here, there's sadness and increased sleep, decreased sleep, the whole gamut of things. So moving into what are some interventions that we can consider. So from the oncology team perspective, I think it's important to note that screening for adequate treatment of psychological sequelae is important. Looking at just simply asking the question, is a person feeling down? Are they struggling with anxiety? Can we connect them to some additional social support? We're very fortunate here that the oncology team excels in that area and readily introduces psychiatric services at the onset of illness, which I believe really helps to normalize the importance of treating the psychiatric and emotional side of cancer, just like we do the physical side. Looking at targeted interventions to improve physical well-being, and then interdisciplinary collaboration and referrals to specialized services. The psychiatric team, our role is to help with the diagnosis and get the appropriate psychiatric diagnosis, make sure we're using the right therapies, and then also pharmacological management where necessary. It's important for us to normalize and validate what the patient is going through, and just ensuring that we understand what symptoms that they're at risk for and how do we get them connected to treatment. We also want to look at symptom assistance related to quality of life. I'm very excited to share that on April 26th, with the next upgrade here in our local system, there will be order sets that include all of our supportive care options that will be on inpatient admissions as well as our ambulatory orders, but that I will not go into that because it's specific to our program here. So what are we thinking about when we're looking at what are the treatment considerations? So not all depressive or mood syndromes are the same. Not all patients are the same. What we're trying to do is trying to get to an understanding of what symptoms are present, what is the intensity and persistence, and how do we start to weave out the predominant factors that the patient is struggling with. What are the things that are interfering with their ability to maybe meet treatment demands, as well as interfering with enjoyment and functioning? So sometimes we're going to utilize non-medication based interventions such as talk therapy, and sometimes we're going to turn to medications, and oftentimes we're going to use a combined approach. In addition to determining if the patient requires psychopharmacological agents, we're also trying to validate their experiences, help them with communication challenges across their support systems, as well as with their medical teams, and then really working as liaisons back and forth to the medical team to ensure that the patient understands the language that we're using and the terms that we're talking about. So as I've kind of talked through all of the things that we're working through as psychiatric providers, it is probably difficult to know if I am the picture with the jumble above my head or the one with the neat little yarn balls. But the reality is we're trying to take this jumble, make some sense of it, and give patients tools that they can utilize to cope with their illness, as well as identify interventions that will be helpful for them. Moving on to what I think will be the pharmacist's favorite slide of the presentation. My colleagues at Memorial Sloan Kettering, Drs. Roth and Nelson, put together a book here in this last year looking at psychopharmacology in cancer for prescribers and non-prescribers. It's really important for us to understand what are the common psychiatric medications that are prescribed, as well as what are the ones that we need to watch for any interactions in their chemo regimens, as well as other medications that they need to be on throughout the course of their medical illness. So interesting to note that 10% of adults in the United States fill one or more antidepressants, and oftentimes oncology patients will present with clusters of symptoms that we can treat patients for. So for instance, if a patient might be struggling with fatigue or difficulty concentrating, we may be looking at a medication like bupropion or a psychostimulant or another wakefulness medication. Whereas if a patient's having more difficulty with anxiety, poor appetite, and inability to sleep, we may be looking at utilizing a medication such as mirtazapine, or even using something like olanzapine off-label. Back to the importance of communication being important. When patients are prescribed medications off-label, especially in the context of psychiatry, really educating them that I don't think that they also, now on top of having a new hematologic malignancy, they don't also have schizophrenia or bipolar disorder. That's incredibly scary for a patient, and very, very important for us to clarify. This is our big ball of yarn that we try to make into this beautiful blanket and help patients get through their illness with as good a quality of life as possible, and as much support around them as we can. So with that, I will stop and see if anyone has any questions.
Thank you, Elizabeth. That was wonderful. I do have a question. So it seemed like several years ago, maybe when they first came out, the new Vigil, Provigil was being used a fair amount, and I see less of it being used now. Is there a reason for that, or?
I think some of that is we've switched over to using different antidepressants more consistently first line. But no, you're right. I was thinking about it again as I was writing the talk, that there probably is more opportunity in the context of fatigue, especially, to kind of recommit to the more use of those agents.
Thank you. And we do have a question. I said, go ahead.
Well,
Dr. Mallon.
While you were talking, I was curious if there is any data that is being developed or has been historically developed where a pre-treatment psychologic assessment could help guide which therapeutic options that medical oncologists would eventually select. Like if there were two that were equal in efficacy, or at least presumed equal in efficacy, like dose-adjusted EPOC versus RCHOP, for example, there is some data that guides decision-making, but that's still a relatively unresolved question. Like if there was some sort of like psychologic assessment that could help guide which would be appropriate for a patient.
Not that I'm aware of, but certainly I can see the importance of understanding a patient's capacity for tolerating treatment and why that would be important to medical decision-making and treatment choice.
And also with a quick question, I think, from the audience, which is, do BMT patients go through a psychological evaluation before transplant?
They do. Yes, that happens at the transplant center, but that is part of pre-transplant evaluation.
Thank you very much again. Any other questions? Thank you, Elizabeth.
Thank you.
That concludes program 3. I'd like to thank our program 3 speakers, Doctors Archer Nanda, Dr. Pagan, Dr. Cosfeld. Dr. Becky Champion did such a good job. I've asked her to join me for the next session, chronic myeloid leukemia. When is enough enough?